Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Guys, I'm back today as promised, and we're discussing different types of medical coders, and today we're talking inpatient coding. I want to start by saying, as an inpatient medical coder, I am my facility's moneymaker. Let me say that again. As an inpatient medical coder, I am my facility's moneymaker. Remember when I did the physician office medical coder on the different types of medical coders, and when I did physician office medical coder, I said, I am my physician's moneymaker. Well, as an inpatient medical coder, I am my facility's moneymaker. The goal of inpatient coding is to translate the patient's stay in the hospital into ICD-10 diagnoses codes and ICD-10 PCS procedure codes. Now notice the difference. In the physician office coding, for the diagnoses, I coded ICD-10 and for the procedures, I coded the professional side with CPT. But as an inpatient coder coding inpatient visits, I code procedures with ICD-10 PCS for the procedures that are performed in the hospital which is the facility, for facility reimbursement. But that same procedure that's performed in the hospital that I, as an inpatient medical coder, will code with ICD-10 PCS, the physician that performs the surgery, their physician office coder will code that same surgery with CPT so that the physician will get reimbursed for performing the procedure in the hospital, while the facility with ICD-10 PCS will get reimbursed for the procedure done in the hospital. I hope that makes sense. Key I'm saying here is the surgery that's done in the hospital by the physician. Physician will get reimbursed with CPT. Hospital gets reimbursed with PCS. Just know that medical coding on the inpatient basis is based on the entire stay in the hospital. So, where is inpatient medical coding performed today? Inpatient medical coding can be completed in an inpatient setting and or remotely from home. Due to the electronic medical record, access to the medical record can now be accessed online from wherever the coder is, if the facility allows it. So when is inpatient coding performed? I say medical coding in the inpatient setting is performed prospectively, concurrently, and or retrospectively. How is that possible? Well, prospectively, when the patient, we have an idea already for inpatient stays because they're based on DRGs. Prospectively, we have an idea already for each DRG what the reimbursement rate will be. So prospectively, we already know what type of patients we'll be seeing and approximately how much reimbursement we will be receiving from the third-party payers. Now, concurrently, while the patient is in-house, as the director of HIM, I oftentimes would have my coders, my inpatient coders, start viewing the chart online. Start looking to make sure all of our documentation needs are being met while the patient is in-house and while we can still leave notes to the physician. Please give greater specificity here. Please identify this. We can still communicate with the physician while patient is in-house concurrently. And then retrospectively, after the patient's discharged, is when we go in and kind of fine-tune and complete all of our coding for that inpatient stay. I'll explain a little more as we get a little further into this discussion. So, who should perform inpatient medical coding? The way that I often answered this is I would say your strongest medical coders. Your strongest medical coders should do inpatient medical coding. The reason I say this is because the inpatient medical coding, with inpatient medical coding, the coding is based on the entire inpatient stay, including all facility-related charges, such as days in the hospital, supplies used, and the procedures performed. So a lot comes into inpatient coding. On an outpatient, we can code those signs or symptoms. But on an inpatient, if those signs and symptoms lead to that definitive diagnosis, then all we're concerned about is that confirmed diagnoses. But on an outpatient, a lot of times you don't have the lab work, the x-rays, the ancillary services that physicians will send a patient out to get performed before the next visit. We just have signs and symptoms. Well, there's no excuse when the patient's in-house. When the patient's in-house, you can get those labs, those x-rays, those respiratory notes, whatever you need while in-house and while patient is still there to get the results. So that's why I always say your strongest coders, because everything you need should be there, but you gotta know to look for it. So how is inpatient medical coding performed? The key to inpatient coding is identifying the principal diagnoses based on the inpatient stay. And I like to say the same goes for outpatient as well. But you must identify the principal diagnoses. And then additionally, reporting additional diagnoses, which are those diagnoses that require clinical evaluation. If I'm going in for one thing, but by the way, I also have hypertension, and you're going to have to monitor my blood pressure. I have diabetes. Blood sugar checks should be done throughout the day, checking my blood sugar levels. Additionally, reporting additional diagnoses, which are those diagnoses that require clinical evaluation, therapeutic treatment, diagnostic procedures, anything that extends the length of stay for the patient while they're in-house, or requires additional or increased nursing care and or monitoring. And my students often ask me, what does that mean, increased nursing care or monitoring? Well, if you have a patient with, say, for example, Parkinson's, they tend to, with the shaking, they have to help, the nurse calms them. Or if the patient is blind, they need assistance to the bathroom. Or if the patient has dementia, we tend to have to watch them a little closer. So increased nursing care can justify capturing those diagnoses as well. So keep that in consideration. And also, in addition, inpatient coders now have to identify diagnoses that are present on admission. Wait a minute, Coach, what? For so long, hospitals have been blamed for conditions that patients actually came in with. But for some reason, family members didn't know it until after a good example, decubitus ulcers. We were getting patients from the nursing facility. Family members hadn't seen their loved ones in a while. And when they hear the patients in the hospital, by the time they get to the hospital to see their loved ones, well, they've got decubitus ulcers on their back, and they're blaming the hospital for the decubitus ulcers. But you can tell from the stage of the ulcer that the ulcer didn't happen while the patient was in the hospital. The patient had to have come in with it, but we have no documentation of it. So now inpatient coders are required to identify those conditions that the patient had on admission. That way, the hospital is not liable for those conditions. And you'll see that a lot in not just the hospital and nursing homes as well. If the patient leaves a facility, a nursing home, and when they come back, they don't tend to go right back to their own room. If they're not in a private room, they're going to a private room for up to 24 hours so that the nursing home nurse can check the patient to make sure from head to toe, make sure there are no open wounds or sores or anything that are beyond control. Well, that's what happens in the hospital. Patients come in, and from head to toe, the nurse will check and identify birthmarks, moles, open wounds, etc., that the patient has come in with, so that they can identify that these were present on admission. They didn't happen while patient was in-house. All right. Also, another thing that needs to be taken in consideration with inpatient coding is that Medicare is the largest third-party payer in the United States. And Medicare requires what we call MSDRGs, or Medicare Severity Diagnostic Related Groups, for reimbursement. And that's where the DRG is based on the selection of the principal diagnoses, principal procedures, and any secondary diagnoses. So Coach, my students say, Coach, how can you explain that to me so I understand this better? Well, think of DRGs or MSDRGs as a tree. As the tree grows, you end up having branches that go off of the tree. Well, think of those branches as body systems: digestive, reproductive, cardiovascular. Think of the different body systems, respiratory. Well, as the limbs, the limbs grow off the tree, they often grow off branches off of the limb, and those branches are what we call diseases of those body systems. So think of the branch as the body system, and then from the branch, those limbs that grow off of the branch are different diseases of these body systems. Well, DRGs are given a relative weight that considers what all is involved in treating each one of these diagnoses of these body systems. And then it also takes in consideration comorbidities, which are additional diagnoses that the patient has that will be treated while the patient is in-house, or any complications that may occur while the patient is in-house. And these CCs, complications or comorbidities, can increase the weight of the DRG. Now, each facility is given a relative weight on services that they render. So I like to say 2 hospitals can be right beside each other, but a facility rate at one hospital might be one rate, and a facility right beside it might have a higher facility weight. Well, if the DRG is a certain, with each facility given their own weight, you multiply the facility rate by the DRG rate to determine the reimbursement. So if these 2 facilities that are side by side, if one has a higher facility rate, then when you multiply that higher facility rate by the DRG, the reimbursement is going to be higher than this facility whose rate is lower times the DRG, which is going to bring in a lower weight for the reimbursement. I hope I explained that sensibly so it makes sense. And then because of the additional factors that come into play with inpatient coding, then your productivity standards are not as high for inpatient coding as outpatient coding. Because again, remember, there's so much more that's taken in consideration. You can come in with a headache on an outpatient basis. On an inpatient basis, we tend to know that a headache, which is usually a symptom of the patient, can lead to a definitive diagnosis. Well, as an inpatient coder, I'm looking to see what is the purpose of the headache. Why is the patient having these symptoms? So because of the more in-depth coding that's involved, research that's involved, knowledge that's involved, the productivity standards are not as high for inpatient coders as they are for out. And I think the last standard that I looked at was 7 to 10 charts an hour. So it's not as high as ER or outpatient or even physician office coding, because more factors are coming into play. All right. This is just giving you a quick overview of inpatient coding. But remember when I said the coding is done prospectively, concurrently, and retrospectively? Prospectively, again, we have an idea based on the admitting diagnoses which DRG the diagnoses, the principal diagnoses will more than likely fall into, and therefore we have an idea of how much money is being on hold for patients that are in hospital. We have an idea of how much money. As the director of medical records, I would get a report every morning that would account for every patient that was currently in-house and approximately how much money was being held up, on hold, or if the patient had already been discharged, I could look at the idea. They have an idea of about how much, based on that admitting diagnoses, how much money is outstanding and needs to be coded. And so our goal with inpatient coding was to have that chart coded within 7 days, 1 week of discharge. And that's with hopes that the physician completes their discharge summary or all their documentation so that my coders could code all the coding they needed to do on the chart. All the lab work, all the x-rays, everything that was needed was on the chart so that my inpatient coders could code the chart. Guys, that's just a quick overview of inpatient coding. I hope it gives you a little better explanation of what inpatient coding is. Next week, we'll discuss outpatient medical coders. Outpatient medical coders. Thanks, guys. I'll see you in the next one.